Hello, my name is Julia Sharif, and I am an assistant professor in the Division of Endocrinology and Molecular Medicine at the Medical College of Wisconsin. And today we're going to be talking about hypercalcemia. Our objectives for this talk: first, we're going to review symptoms of hypercalcemia and what to look for. Then we're going to discuss potential causes of hypercalcemia and differences between parathyroid hormone mediated or PTH mediated and non-PTH mediated disease. We will then evaluate the diagnostic process specifically for PTH-mediated hypercalcemia, which is what we see in endocrinology. And then we will discuss the treatment of primary hyperparathyroidism, which is a type of PTH-mediated hypercalcemia. So symptoms of hypercalcemia can include some mild or moderate symptoms like constipation, fatigue, weight loss, muscle cramping, polyuria, or polydipsia. And it can range from mild to moderate up to severe, which could include certain cardiac arrhythmias, confusion, or lethargy. Or patients can also become asymptomatic with this. They don't have symptoms with the hypercalcemia. Potential causes of hypercalcemia, again, divided into PTH-mediated and PTH and non-PTH-mediated causes. First, PTH-mediated, we have primary hyperparathyroidism, which is what we see the most in our practice. And then we also have something called familial hypocalciuric hypercalcemia, or FHH. The list of non-PTH-mediated causes is quite long, as you can see, and this is just a list of some of these conditions. So there are more. So some of them are PTHRP or PTH-related protein related. There also are medications such as Tums that could lead to milk alkali syndrome, multiple myeloma, other endocrine conditions like adrenal insufficiency and acromegaly, thyroid disease, and then vitamin D toxicity, and some rare genetic diseases related to vitamin D as well. So this is, again, not a complete list because there are many more rare causes, but this is some of the conditions associated with non-PTH mediated hypercalcemia. So what are some differences between PTH and non-PTH mediated disease? So the big one is PTH. So that's kind of your first step. So the big thing is when you have a patient with hypercalcemia, you want to check a parathyroid hormone or PTH fasting at the same time as you get your calcium level, because PTH in isolation doesn't tell us anything without the calcium. So PTH, if it's high or inappropriately normal, there could be PTH-mediated disease causing the hypercalcemia. Or if the PTH is low, then this could be related to non-PTH mediated disease. And then you also want to assess for other causes. Again, relating back to that list, PTHRP, vitamin A, cortisol, ACTH, IGF-1, TSH, and then 125 vitamin D. You can also look for malignancies via imaging. So we're going to focus a little bit more today on PTH-mediated disease because this is a little bit more endocrine specific. So first we'll start with the anatomy. So PTH comes from the parathyroid glands. These are four small pea-sized glands located behind the thyroid. Their role is to regulate calcium balance in the blood, and they do this at the level of the bone, kidney, and the gut. When everything is in balance, PTH and calcium should both be normal. And if calcium is low, for instance, PTH should rise normally in response to bring those levels up. If calcium is high, conversely, PTH should be suppressed because it's no longer needed to increase those calcium levels. And to increase those calcium levels, again, it can lead to increased bone resorption, increased kidney calcium resorption, and gut resorption and gut absorption. And this is a negative feedback mechanism, which is something that's pivotal in a lot of endocrine problems. You have a signal that's feeding back to the original organ and suppressing that function. So again, this is a little bit of an overview. I know some of it might be blocked by the camera, but PTH is secreted. It leads to increased calcium reabsorption and decreased phosphate reabsorption at the kidneys, increased bone resorption at the level of the bone, and then increased calcium and phosphate absorption at the gut. This leads to an elevation in plasma calcium, which binds to the calcium sensing receptors, which feeds back to the parathyroid glands and tells them about the calcium status in the body. Primary hyperparathyroidism. The parathyroid glands in this condition secrete inappropriate amounts of PTH, and this results in high calcium levels. This is usually due to sporadic mutations, but can be a part of an endocrine disorder such as multiple endocrine neoplasia syndrome. This can lead to osteoporosis, kidney stones, fractures, and again, some non-specific symptoms that we talked about earlier. To diagnose primary hyperparathyroidism, we first need to obtain labs. This is a biochemical diagnosis. So you first need to get calcium labs, first and foremost, albumin, because this allows us to correct for the serum calcium in case there are low levels of albumin. Low levels of albumin corrected will allow us to see the true level, which will be higher than what is measured. Vitamin D, creatinine for kidney function measurement, and ionized calcium, which also might help clarify the diagnosis, parathyroid hormone, which is done fasting, and then a 24-hour urine calcium and creatinine. This is done by the patient at home where they collect their urine for a full 24 hours. The things we're looking for include a high calcium with a normal or high PTH. The normal PTH signifies that it is not being suppressed as it normally would by a high calcium. So this is still abnormal, even if the PTH is technically normal. This is an acquired process, meaning the patient has not had this their whole life, and you should be able to see a time in which the calcium levels begin to rise or start to gradually trend up. This can often be difficult because patients with primary hyperparathyroidism often have calcium levels that fluctuate. So you might see a higher normal calcium level, one check, and then a frankly elevated calcium, another check. So it's important to look at the trends. If they've had a stone cold normal calcium in the mid nines for several years, and then all of a sudden we're up to 10.5, then that could be a sign that they're developing primary hyperparathyroidism. And if this is sustained over a long period, you definitely want to make sure that this is investigated fully. A 24-hour urine collection does aid in differentiating between primary hyperparathyroidism and FHH, which we will talk about a little bit more later. Imaging can also be important. A lot of times it's not diagnostic, though, for primary hyperparathyroidism. It's a biochemical diagnosis, as I mentioned earlier, but it may help with surgical planning. And there's also other types of imaging that we should be obtaining to look for other comorbidities related to primary hyperparathyroidism. So, for instance, a bone density, a DEXA scan, would be helpful to determine if the patient is having any bone health impacts like osteopenia and osteoporosis. A renal ultrasound would be helpful to look for kidney stones that could be associated with primary hyperparathyroidism. And then a CT, neck, or ultrasound of the parathyroid would also be helpful from a surgical planning standpoint. So this is not usually something that we order, but sometimes the surgeons will order for surgical planning. A good point to make is we don't routinely use sestamibi scans as they're not the most sensitive for primary hyperparathyroidism diagnosis. And again, it's not an imaging diagnosis, it is biochemical. So it's not something that we typically order because if you have a normal sestamibi scan, you still could have an underlying parathyroid adenoma. So that's something to keep in mind as well. So another cause of PTH-mediated disease is familial hypocalciuric hypercalcemia, or FHH. And this hypercalcemia has been present since birth. This is a condition where the calcium sensing receptor has a mutation, and this mutation can lead to higher levels of calcium due to lack of negative feedback on the parathyroid glands. And this can involve monitoring, but does not typically involve surgery to treat it because you won't actually change the underlying condition. Therefore, it's very important to differentiate this from primary hyperparathyroidism. So diagnosing FHH, similar lab patterns to what we talked about. And again, typically hypercalcemia is present since birth. Genetic testing is also going to be helpful for mutations in calcium sensing receptors. Differentiating between the two, we use the calcium creatinine ratio, and a serum calcium and creatinine values will also come into play with that. So the way we do that is we use the urine calcium multiplied by the serum creatinine divided by the urine creatinine times the serum calcium. And this should be done in the same types of units when you're cross multiplying. If this ratio is less than 0.01, FHH is likely and primary hyperparathyroidism is unlikely. If it's between 0.01 and 0.02, FHH is less likely, primary hyperparathyroidism is more likely, but not confirmed. And if it's greater than 0.02, it is likely primary hyperparathyroidism. However, there is some nuance to this, so keep that in mind. So patients who have chronic kidney disease might not be excreting as much calcium. Patients who are on medications like thiazide diuretics or spironolactone may not also be excreting as much calcium in the urine. And then genetic testing. If you are in this gray area, genetic testing might help differentiate between the two and might be able to help you confirm what treatment path you're going to go down. The treatment for primary hyperparathyroidism is typically parathyroidectomy of the culprit glands, and this is usually surgical cure. Surgery is indicated if the patient is under age 50, if the calcium is greater than 1 milligram per deciliter above the upper limit of normal, the patient has kidney stones or renal failure with a creatinine clearance of less than 60, osteoporosis or fragility fractures, and hypercalciuria, 250 milligrams per day for women and 300 milligrams per day for men, or they have symptomatic hypercalcemia. Or if the patient wants surgery, if we make a diagnosis of this and the patient does want surgery, even though they don't meet these other criteria, it's still reasonable to refer them to surgery, as this again is surgical cure, and it may help prevent some of these other things from happening down the road. So surgical risk, the main risks of infection and bleeding can happen. Hypoparathyroidism is also of concern, so you want to make sure you have an experienced surgeon that is doing this procedure to help avoid and minimize risk of hypoparathyroidism. This is where you have damage to the parathyroid glands that may lead to hypocalcemia that may be transient, but it could be permanent. And this can be really difficult to manage down the road and is very hard on patients. There could also be damage to the nerves innervating the vocal cords, so that could happen as well, leading to hoarseness. So those are some of the risks that we see commonly, or that we counsel on commonly, that we hopefully can avoid in surgery. Medical therapy for primary hyperparathyroidism. So if you have a patient that does not elect for surgery, they can be treated medically. So you can treat osteoporosis with bisphosphonates, denosumab, or romosozumab. These are medications that help not only treat osteoporosis, but they can also lower the calcium in the blood. Kidney stones, you can treat with a thiazide, but the thiazides can increase the serum calcium, so you want to use these cautiously. You can also increase fluid intake. You can use surgical intervention and avoid excessive calcium and supplements. And then high calcium levels and associated symptoms. Cinacalcet is a medication that can be used to lower the calcium. It does not improve bone density, however. It increases the sensitivity of the calcium sensing receptors to extracellular calcium. So that is a drug that can be used as well if the calcium is getting too high and the patient's getting symptomatic. So monitoring these post-surgical patients is important. So you want to make sure they're monitored every 6 to 12 months in the initial time frame and then annually thereafter. Calcium, creatinine, albumin, PTH are some of the things you would monitor, as well as vitamin D, ideally annually. And then a bone density is done ideally 1 year after surgery, depending on insurance coverage. Recurrence can occur, especially with patients with multiglandular disease or some of these genetic syndromes associated with primary hyperparathyroidism. Repeat surgery can be difficult for these patients. So once they have one neck surgery, there might be a lot of scar tissue involved in that area, so it can be difficult. So you may want to treat these patients medically if they do have a recurrence versus going back in and treating surgically. Genetic testing is recommended for those who are young and for those who have multiple gland disease, so this might be something to consider as well. And those opting for observation should have labs as above and periodic DEXA monitoring as well if they are prone or at risk for osteoporosis too with this primary hyperparathyroidism. Thank you for your time, and hopefully this has been a good introduction to hypercalcemia.